if we start talking about depression, is that there's a trilogy that I see in my patients. And I wonder if you see this too. You could maybe think to some of your patients whom you've diagnosed depression in over the past couple of months. So the first is genomic risk, and we know which genes put people at a greater risk of depression. Then there's, I would say, pathogenic activity in the gut. So it might be increased intestinal permeability, it might be dysbiosis, it might be a loss of diversity. And then you add on top of that a trigger. It can be a trigger like a divorce, it could be a trigger like losing a loved one. But you put those three things together in a vulnerable individual, and that to me is a setup for depression. So I want to keep sketching out our picture of microbiota. I think it's helpful to think about how microbes are involved in a lot of different things besides insulin signaling, which is one of the things I talked about in our first session. They regulate gut motility. And so this is a key part of what happens in patients who have small intestinal bacterial overgrowth, bless you, or SIBO. I had SIBO, obviously, after I had my course of antibiotics. They're also involved in producing vitamins, transforming bile acids and steroids. Examples there are the bacteria that produce beta-glucuronidase. So if you order comprehensive stool analyses, there's certain labs that will run a beta-glucuronidase for you. And when I first started looking at that about 15 years ago, I was just amazed at, oh, my patients with estrogen dominance have high beta-glucuronidase. And I can do something about this. I can help them with reducing beta-glucuronidase activity. There's ways we can do that. They also metabolize foreign substances, they absorb minerals, and they help to activate and destroy toxins. So one of the things, as I always scan my practice for what's changing, what's evolving, what's coming next, I would say that the way I was taught in medical school, and I wonder if you were taught this too, I was taught that if a patient came to see me, this was after I decided that I was going to go into OBGYN, if a patient came to see me with endometriosis or polycystic ovarian syndrome or perimenopausal vasomotor symptoms, I would treat those. So that was my job. But if they had anxiety or depression, I was supposed to ship them off to mental health professionals. And I think that split really has come into question with our understanding of the gut-brain axis. This idea that we would split a patient into two halves and treat their physical symptoms over here in the non-psychiatric departments and treat their anxiety and depression elsewhere, I think is changing. So I just want to put a plug in for thinking more integratively and holistically about what our patients are facing.